I've always been fascinated with facial pain, both myofascial pain and intra-articular pain and dysfunction, i.e. TMJ pain and dysfunction, and the treatment of trigeminal neuralgia, which I don't treat. But today we're going to talk about myofascial pain and especially the treatment, the conservative treatment of intra-articular pain and dysfunction, i.e. TMJ problems. This young lady has one disc that's anteriorly displaced reducing and another disc that's anteriorly displaced non-reducing. She's a sophomore in the music education. The left TMJ has been popping the last few years. She has difficulty opening her mouth. She was given a steroid by a dentist, but it came back again. Most dentists have no clue how to treat TMJ and myofascial pain. That's why there's so much joint surgery, because they get referred to really nice people. I was in an oral surgery fellowship for 2 years, so I have the greatest respect for surgeons. But surgeons are the great dumping grounds of dentistry and medicine. If physicians don't know how to treat something dentally, or dentists don't know how to treat something dentally, they dump them on the poor oral surgeons. Well, the surgeon says in his mind, okay, the dentist doesn't know what to do, so I'll do what I do, which is some type of surgery. Surgery is not indicated most of the time, never in myofascial pain, and hardly ever in intra-articular or TMJ problems, unless you've got some big disease process of the joint system and you're replacing the upper and lower joint. In other words, the ball and the fossa, and that's according to Frank Dalwick, who was the head of the head surgeon at the Parker Mahan Center for Facial Pain in Florida, who's been to our teaching center many times. So there's lots of different opinions on TMJ and myofascial pain treatment. The system I'm going to teach you is one that took me 25 years to figure out. I've used it for the last 15 years, and I can't remember a single case in which it did not work. Now, what does work mean? Work means the patient is, in the end, can open comfortably to 45 millimeters without pain. Functional and comfortable most of the time without surgery. So they can open to 45 millimeters and they're comfortable. Now, sometimes a pop and a click will not go away for a while. Eventually, that does go away, but a pop and a click, an anteriorly displaced reducing disc, is actually harder to treat than an anteriorly displaced non-reducing disc. So I'll talk about that more as the video continues. So it hurts to open her mouth wide in the left TMJ, grinds her teeth, and there's much tension in the jaws. She's never worn a night guard. Her dentist has never mentioned it. And no dentist has ever mentioned TMJ treatment except for the steroid she was given, which did not work. So we're not finding popping in either TMJ. She says there's an occasional pop in the left TMJ. Her maximum opening was 32 millimeters plus 1. 1 means her vertical overlap. Now you remember the normal opening is about 40. And this was a strained opening. She has 10 plus eccentric limits, meaning she can move the jaw left and right 10 plus, but there's popping when she moves the mandible to the left. The first contact in centric relation is the left molars. There's a 1 to 2 centric relation to centric occlusion slide. Now, I took a sedation course this weekend, and there was a young woman in the course, and we were talking about centric relation, and she was convinced centric relation makes no difference, that there's no consequence, that you shouldn't pay any attention to it. Well, I can't practice dentistry without centric relation. It's the beginning point of everything. If you don't have centric relation, how do you start a complex case? Think about all the joints in the body When that system is under stress, you want the ball maximally seated in the socket, don't you? The knee joint, the elbow joint, shoulder joint, when you're running on that knee, don't you want that ball maximally seated in the socket? Well, the same thing is true of the TMJ. When you're grinding your teeth, you want the ball to be bone braced. If it's not, it has to be muscle braced, and those muscles and ligaments and retrodiscal tissue eventually break down if it's not bone braced. So I didn't get into a big discussion with this young woman, but that's just the way it is. If you don't have centric relation and you're trying to rebuild a mouth, where do you start? And as we get more and more into these cases, I'm going to teach you how to reconstruct an entire dentition, especially in cases where the person has lost vertical dimension and we're increasing vertical dimension. You have to have centric relation, which is your beginning point. So she's got a 2 millimeter slide from CR to centric occlusion, and she contacts first on the left molars. All the muscles of the face were positive to touch. She's got tooth wear of the upper and lower anterior teeth. If the patient has a malocclusion, i.e. a CRCO slide, and they grind their teeth, then that's like running on a leg that's shorter than the other. Now, you know, some people say, well, occlusion doesn't have anything to do with myofascial pain or intra-articular / TMJ pain. Balderdash, of course it does. It's the reason that, and the reason I say that is because some people with a malocclusion don't have myofascial pain or TMJ intra-articular pain and dysfunction. Why is that? Think it through. The system is not under stress. If you've got a leg this much shorter than the other and you never run on it, you sit in a chair all day, you walk to your car, you drive home, you eat dinner, you go to bed, there's no stress on the imbalanced system. So as a consequence, you're probably not going to have any pain and dysfunction of the leg. On the other hand, if you jogged 3 miles a day on that leg that was short, that much shorter than the other, you're going to have muscle pain, you're going to have knee pain, foot pain, hip pain, back pain, because you're placing stress on an imbalanced system. So that's why not all people that have a malocclusion have facial pain or intra-articular problems. The equivalent of jogging on a leg shorter than the other is someone that grinds their teeth at night when they're sleeping with a malocclusion. Remember, the only time teeth should ever contact is when you swallow, and then very lightly. The teeth don't contact when you chew your food, and as you go through the day, the teeth should not be in contact. Try this. The only time they should contact is when you swallow, and then very lightly. So in that situation, the only time occlusion makes a real difference is when the person is clenching their teeth, because they shouldn't contact any other time. So these are parafunctional habits when people are grinding all night long. That's why most of my patients have a Nightguard, and almost all the young people in my practice get a Nightguard once they've stopped growing. Could some of them live without it? Probably. You know, some of them may not grind their teeth, but most of us will over time. And if they have a Nightguard, from the time they quit growing, and that's a flat plane, hard acrylic, centric relation, occlusion, Nightguard, if they have that Nightguard, their teeth will be the same length when they're 80 as they are when they're 20. So these are the results of the examination. I look forward to assisting you with your dental issues. During the examination appointment, you said your left TMJ has been popping the past few years. You now have trouble opening your mouth, and your left TMJ area hurts when you do open your mouth. You've had orthodontic treatment twice, but you stopped wearing your retainer and your teeth shifted. Your dentist in Garland gave you some steroids and it helped, but the problem is back. Your voice teacher at Baylor referred you to me. You said you grind your teeth and have much tension in your jaws. You mentioned you eat fair amount of sweets, which doesn't have anything to do with this. You do not wear a night guard and have not been treated for TMJ dysfunction other than the steroid prescription. These are the results of the examination. Your mouth opening is limited to 32 millimeters. The average mouth opening is 40 millimeters. There's occasional popping of the left TMJ. All the muscles of mastication in the face are sore to palpation and they're very tight. The first tooth contact when your jaw joints are properly positioned in the jaw joint, centric relation, is the left molar area. There's a 1 to 2 millimeter slide from centric relation to centric occlusion. All 4 wisdom teeth are present and impacted. There is a beginning cavity on the lower left second molar teeth and there's quite a bit of stain. The MRI results. Both the left and right TMJ disc are anteriorly displaced. The right disc reduces upon opening. The left disc does not reduce upon opening but remains anteriorly displaced. And you'll remember that's the painful joint. And then this is the treatment. And I make the note, the objective of this conservative treatment is to help you become comfortable and functional most of the time without surgery. There's always a possibility surgery could be required, but I've not had a TMJ patient have surgery that I'm aware of in over 30 years. So these are the MRI results, and we'll look at that MRI in just a moment. The right TMJ, there's anteriorly displacement of the meniscus with the jaw closed. During opening, there's normal reduction of the meniscus as the mandibular condyle slides forward over the meniscus. The left TMJ, there's anterior displacement of the meniscus with the jaw closed. During opening, the meniscus remains abnormally displaced anteriorly. You can't always diagnose anterior displacement with reduction on an MRI. Remember, anterior displacement with reduction of a disc results in a pop and a click. So if the disc is not very anteriorly displaced, you may not be able to see that on an MRI, but you'll diagnose it clinically because the patient pops and clicks when they open and close that jaw. Now, an anteriorly displaced non-reducing disc is all wadded up anterior to the condyle. And when you look at that on an MRI, at first you may say, oh, that's the reason the patient can't open. Not always the case. The retrodiscal tissue may be completely stretched out and that disc is just moving forward of the condyle so that the retrodiscal tissue is not grabbing. That could be just myofascial pain and dysfunction that's causing the patient not to open. But it's nice to know with the MRI that you have an anteriorly displaced non-reducing disc. Left TMJ is anteriorly displaced and non-reducing. The right TMJ is anteriorly displaced and it reduces, so you would expect the right TMJ to be the one that's popping and clicking, and probably the left TMJ popped and clicked at one time before the retrodiscal tissue stretched completely out and the disc became anteriorly displaced non-reducing.
Whenever I open my jaw hard, like it's not as far as I used to be able to open it.
So she's constricted on the left side, and remember that disc is anteriorly displaced non-reducing. So it's just wadded up.
It feels like there's like a bump there that's like keeping me from opening it, and okay. it's like pushing against it, but it's not able to like open the door.
She's perfectly described an anteriorly displaced non-reducing disc. Feels like there's a block in front of it. Mm-hmm. Now, do you feel anything on this side?
No.
Not really?
No,
and how long has this been going on?
It started locking up like 2 months ago, mm-hmm. and then before that it had been popping for years.
Okay, so you'd had a pop for years and mm-hmm. it started locking a couple months ago. Mm-hmm. Okay. And that's what you expect with an anteriorly displaced non-reducing disc. It usually first goes through the popping stage, which means it's anteriorly displaced but reduces. That means the condyle pops back onto the disc and it functions normally in the anterior part of the translation part of the movement, and then when the patient closes, the condyle pops back off of the disc. So that's a pop and a click. Now she's progressed from that to the anteriorly displaced non-reducing. So it's wadded up like a door jamb in front of that left condyle. Let's go first to the right TMJ. Now the right TMJ is anteriorly displaced, reducing. So you would expect a pop and a click in that joint. So here's the auditory meatus or the ear hole, here's the fossa, here's the condyle, and here's the disc with the patient's mandible completely open. So they're open here, and when they close, the condyle is going to go back into the fossa. You can see here's the auditory canal, here's the fossa, here's the ball, and there's the disc. Now you can see it's a bit anteriorly displaced on the right, but then it reduces. The ball actually goes back onto the disc once she opens, but then it comes off of the disc back in the fossa. Let's look at the left side. There's the auditory meatus, fossa, ball. Here's the disc. Now watch the disc bunch up as she opens. See, the disc does not reduce back onto the head of the condyle. Now remember, reduce means goes back where it should be. If someone has a compound fracture of the arm, the bone of the arm, reducing the fracture means putting the bone back where it's supposed to go. So this disc does not go back where it's supposed to go. It's gone from anteriorly displaced reducing to anteriorly displaced not reducing, and now she's blocked when she tries to open on that side. See how it balls up in front right here? See, rather than the ball getting back onto the disc like it does on the other side, when you have a pop and a click, the ball pops onto, the condyle pops onto and off of the disc. Here it's just wadded up because all that retrodiscal tissue is torn. So the condyle is never back on the disc.